So hello everyone, welcome to our Zoom meeting. Today we'll have the purple team present and Dr. Mohammed will be moderating the Zoom meeting. So when you have a chance, Dr. Mohammed, please go ahead. I'm gonna stop sharing.
Okay. Hello, everyone. My name is Dr. Mohammed. I'm a junior fellow. I want to thank all of the attendees, and I want to thank Dr. Nader for giving us the chance for having a seat in this esteemed and famous fellowship program. Welcome all. In case that you wanted to participate, ask any questions, feel free to use the hand raise feature on the Zoom, or just type your questions in the chat box and I will pass them either to the presenter or to Dr. Nader to keep a nice flow of the session. We will start by a presentation about Google Scholar and ResearchGate. I'll be presenting alongside my colleague, Dr. Alhaj. Hi, Muna. You're muted, Muna.
Ahlan, Dr. Alabadi. Hello, everyone. So Dr. Alabadi and I will start our presentation for today. Give me a second to share my screen. So hello, everyone, and welcome to our presentation. Today, me and Dr. Mohammed Alabadi will walk you through a very nice and delight topic, ResearchGate and Google Scholar. So we will delve in the world of online academic platforms. We will talk about ResearchGate and Google Scholar. We will explain and explore their strengths, their weaknesses, and how to best utilize both of them for your research. So in the recent years, we have seen a dramatic shift in how research conducted and shared. Online platforms have become more indispensable for staying updated, collaborating, and disseminating findings. Despite the wealth of information available, researchers often struggle to find relevant studies. Collaboration can be hindered by the geographic barriers, and measuring the research impact remain a complex task. So the online platform have emerged as a viable tool to overcome these hurdles. They offer efficient research capabilities, foster connection among researchers, and provide metrics to assess research influence. Let's focus on two main platforms for today. We will focus on ResearchGate and Google Scholar. We will explore their unique strength and cater different research needs. So here we go. For ResearchGate is more than just a database. It's a community. It's where researchers connect, share their work, and ask questions, collaborate on projects and publication. ResearchGate offer several key features to support your research. You can share your publication, you can have answer to your questions, to a difficult research question, you can build a professional profile, and even more, you can join to a group focused on your specific area of interest. Here I will share my ResearchGate account and I'll walk you through the basic functionality we already talked about. So here is the homeland or the platform of the ResearchGate. So we will discuss the main functionality of it. First, publication sharing on ResearchGate. It's one of the most primary function of ResearchGate to share your research with the global scientific community. By uploading your paper, you can increase your citation and get feedback upon your work. And it's very simple. You can just press the Add New button. And what's make ResearchGate special, you can share your published research, your preprint, your conference paper, presentation, poster, and even more. The other functionality would make it very special is the question and answer button. The research question and answer platform is a valuable resource for seeking help in answers for the research challenges we all faced. You can ask questions, you can provide answers, and you can engage in discussions. And you can follow the question you asked, and you can follow answer for the question of your interest. Moreover, you can hunt jobs. So most of the institutions provide vacancies in research-related positions. You can bookmark them, you can view them, and you can even tailor them according to your preference, the country you want, the discipline, the institution and company. Lastly, your research profile. Here you can edit your profile because this is your online research identity. You need to complete it in an essential manner to be a valuable place for accurate information to help you increase the visibility and connect and collaborate and attract other researchers. So if you use ResearchGate in a well-based manner, you will have a very good connection and a very good answer to your basic research struggles. Here I explained ResearchGate, and I will take the lead for Dr. Mohammed Alabadi. He will guide us through the rest of the presentation, talking about Google Scholar and exploring the main function and the main difference between the both platforms. You can go, Dr. Mohammed. I will stop sharing my screen.
Thank you, Dr. Mona, for this good insight and nicely designed presentation. I will go ahead and pick up on what Dr. Mona was describing regarding the overlapping functionalities between Google Scholar and ResearchGate. But firstly, I want to give you a brief talk about ResearchGate. Now, about Google Scholar, sorry. Unlike ResearchGate, Google Scholar focuses mainly on academic content. I'm sorry, the screen is still loading. Yeah. So it basically focuses on academic content.
If you're still talking, like you are mute, maybe.
It seems Dr. Muhammad has some technical issue. I think he's frozen. So if you want to carry on, Dr. Muna, if you have a minute, maybe if any questions for the part that was presented for Dr. Muna. So it's one of the important online tools that people can use, and both of them. So here, Dr. Muhammad is coming back. Dr. Muhammad? Or this is Mona. Mona, you are muted.
So what Dr. Mohammed trying to explain regarding the ResearchGate and Google Scholar. In Google Scholar, it's focused solely on the academic. It's a powerful tool for finding relevant research articles and staying up to date for the latest advancement in your field. Google Scholar provides several tools to help you find information. So here we have Dr. Mohammed Alabadi again. Dr. Can you share your screen and
Yes, I apologize about that, guys. I think I lost connection for a minute.
I will stop my screen and
okay.
leave you the stage.
So, as Dr. Rammah was describing, ResearchGate is more of a community-enforced platform. So you can compare it, for example, to other platforms such as LinkedIn, while Google Scholar is a blunt and straightforward search engine. Okay. Google Scholar provides several tools that help you find information that are relevant to your research question, and it allows you to narrow down the search results to what you need specifically. It helps you understand the impact of research, the impact of articles, and helps you refine your research question. Please let me know if my screen is visible. I will share with you the interface of Google Scholar. So this is basically what you're going to see once you type your keywords. For example, I typed here third-degree hat block, and it basically displays the results in a similar manner to regular Google search engine. You have few options here to customize your search. You can customize the timeline. You can customize the search results according to relevance or by date. And you can choose the type of results, any article or just review articles. There are two options in Google Scholar that I find pretty interesting, and I want to walk you through: the metrics and the advanced search option. So the metrics, so we have basically two metrics that are available on Google Scholar. The first is the H5 index metrics. I'll explain that in a minute. And the other is the public access mandates metric. The first one, the H5 index, is a measure of the performance of journals. Let's say you have a research question and you want to publish an article, and you're asking yourself, which journal I'm going to choose. As you can see here, they have a list of the most famous and powerful articles, Nature in the first place, IEEE, and the New England Journal of Medicine. You might be wondering, what is the H5 index? The H5 index is a measure of how much citations does the articles published in this journal had in the last 5 years. So let's say, for example, this is Nature, a very famous journal. You have an index of 488, an H5 index, which means that the articles published in the last 5 years have been cited at least 488 times. The second metric is the public access mandates. Now, if you're looking for a funding for your research project, it might be important for you to get an insight of how much would be available to public access. And this metrics provides an approximate to how much is available. Let's say, for example, National Nature Science Foundation of China. It's a foundation that funds research projects, and research projects funded by this foundation, only 50% of them are available for public access without any sort of subscription or purchase. The second metric, or the second option, I may say, is the advanced search window. I hope my screen, yes, is still alive. So you have these options that will help you refine the way that you pin down or search, narrow your search area. So you can, this option here, find articles, you can include all the words that you want. exact phrases, at least one of the words that you can type here, excluding certain words or phrases. Okay, and you can even choose if these keywords are only in the title of the article or anywhere mentioned in the article. You can also include return articles authored by certain authors or published in certain articles, and make a timeline that you want to look for. Let's say that you want articles that are pretty new. You can make, let's say, from 2020 to 2024, for example. Back to our presentation. You have now a good insight on how does these two platforms operate. So the next point to cover will be the overlapping functionalities of both. So basically, they seem pretty similar while having distinct points of strength. ResearchGate and Google Scholar have different areas of focus. ResearchGate prioritizes social interaction. It's a community-based platform, while Google Scholar, again, is good for finding and analyzing research articles. ResearchGate's strength lies in its community-driven approach. So basically, it's an excellent platform for connecting and sharing and getting feedback. Google Scholar, on the other hand, is an extensive database with advanced search features that makes it a very invaluable tool for finding the most relevant research articles to your research question. Now, to get the best out of both, on ResearchGate, for example, you will focus on building a very strong profile, engaging with the community, sharing your work in a constant manner. In Google Scholar, you'll need to familiarize yourself with all of these metrics. What do they mean, and how to utilize the advanced search options. Now, combining both is the best strategy. Using both platforms in tandem. Google Scholar is ideal for finding research, and ResearchGate is better for connecting and sharing. Now, all of that being said, ethical considerations are a must. It's essential to use ResearchGate and Google Scholar ethically. Always respect the copyright laws, cite your resources accurately, and maintain an excellent level of academic integrity in your research. I think that's all for us today. This would be the last slide. Please feel free to give any feedback, or if you have any questions. Thank you.
Thank you both for great presentation. This is important topic, and one of the things that you should know when you apply to residency, some of the program directors look at your presence on the web. So if you have some publications, you can put some information in either LinkedIn. If you want to add to the Google Scholar, you want to add to any tools online, that would be ResearchGate and others, that would be in your favor when you apply, if they look at your application. But thank you so much, both of you.
Thank you, Dr. Nader, for the
Thank
great
you.
opportunity. We are very delighted, happy to have this presentation present with you again. Thank you, everyone, for listening.
Okay, I think we can go ahead for the next presentation if the presenters are ready. Yeah.
Hello, everyone.
Hello, Dr. Eithar. How are you?
Hello, everyone. Hello, Dr. Nader. Good evening. Thank you, Dr. Nader, for giving me this opportunity. Is my voice clear?
Yes, it is.
Okay. I'm very happy and grateful to be here. My name is Dr. Eithar, and I am G from Sudan. We will continue today's session with a presentation about diabetes mellitus in all adults. Dr. Sara and I will be sharing this presentation, and we hope you find it informative and useful. Dr. Sara, would you please share your screen with me? Could anyone share the screen with me?
I made you a co-host. Can you share the screen or?
Yes, Dr. Sara, would you share your screen with me?
Sure, okay, I'm ready.
Okay, thank you. Okay, thank you. As the population ages, diabetes in older adults is emerging as a critical public health challenge. This presentation will guide you with the essential knowledge to address this growing concern. So, we will dive into the epidemiology of diabetes among older adults and clarify the complexities of classification and diagnosis and explore strategies for preventions and risk management. We will also examine how to conduct through clinical evaluation using the latest evidence-based guidelines. Finally, you will learn how to craft personalized diabetes management plans that honor each patient's unique goals, values, and preferences. We will know about how to manage hypertension, uh, dyslipidemia, and microvascular complication in patients with diabetes. Also, pharmacological management of diabetes. Before we proceed, here is the topic we are going to cover in today's presentation. First, the epidemiology of diabetes in older adults and pathophysiology of it, diagnosis and evaluation of diabetes, prevention of diabetes, also managing diabetes and its complications, interventions of diabetes care, control of comorbid illness, and finally, the education and self-management support. Let's get started on this vital journey towards better health outcome for our aging population. Diabetes is one of the most common chronic disease affecting older adults, and that requires long-term medical attention to limit the development of the devastating complications and to manage them when they do occur. 27% of people over 65 years old have either diagnosed or undiagnosed diabetes. When age adjusts, prevalence higher among Black and Hispanic Americans than white Americans. But when we come to complications, Black Americans suffer from complications of diabetes at disproportionately higher rates than white Americans. Older adults with diabetes have higher rates of vascular complications and geriatric syndrome. 10-year reduction in life expectancy and mortality rate nearly twice that of people without diabetes. They also have a mobility problem. This maybe from complication of diabetes, disability in their activity of daily living. When we come to classification, as we know, diabetes have type 1, diabetes type 1 results from absolute deficiency in insulin secretion due to autoimmune destruction of pancreatic beta cells. And we know type 2 usually due to tissue resistance to insulin action and relative insulin deficiencies. Okay. According to the diagnostic criteria by the American Diabetes Association, there are 4 ways to establish diagnosis of diabetes mellitus. Hemoglobin A1C level of 6.5% or above. This is the primary diagnostic criterion. Or a random plasma glucose of 200 milligram per deciliter or above in patients with classic symptoms of hyperglycemia, polyuria, polydipsia, and unexplained weight loss, and so on. Or plasma glucose after an 8-hour fast more than 126 milligram per deciliter, or plasma glucose more than 200 or equal to 200, measured 2 hours after ingestion of 75 grams of glucose administered after an overnight fast. Please note that this must be confirmed on a subsequent day, preferably by the same method, no adjustment for age here. Prevention of diabetes. Several diabetes prevention trials demonstrate that lifestyle modification that focuses on diet, exercise, and weight loss can delay or prevent progression to diabetes in people with impaired glucose tolerance, who's at high risk for developing type 2 diabetes. Strengths of evidence equal A. Clinical evaluation of older adults with diabetes. First, we have to evaluate risk factors for atherosclerotic disease and presence of comorbid disease. Second, conduct through medication history by review all current and past medication. Assess functional status. Evaluate the patient's ability to perform activities of daily living to determine their overall physical and cognitive function. Screen for common geriatric syndromes like functional impairment, urinary incontinence, falls, pain, cognitive impairment. Okay. Cognitive impairment. Are you with me? Cognitive impairment, depression. These conditions are more prevalent in older adults with diabetes. Strengths of evidence equal B. Perform psychosocial assessment. Consider the involvement of family members or caregivers in patient's care. Identify any barriers to medication adherence, such as cognitive issues, lack of social support, or financial constraints. Yes. What is the goal of the goal of diabetes management? What is the goal of diabetes mellitus management? Goal should be individualized clinical targets for each older adult with diabetes, involving the caregiver when appropriate. Management goals include control hyperglycemia and its symptoms, evaluate and treat associated risk for atherosclerotic and microvascular disease, evaluate and treat diabetes complications, avoid hypoglycemia. Life expectancy and time needed to achieve clinical benefits from specific intervention must be considered when treating older adults with diabetes. This is because some treatments may not show their full benefits until several years later, and the treatments planned should be realistic given the patient's overall health and life expectancy. Clinical trials have demonstrated that greater than 8 years are needed before the benefits of glycemic control are reflected in reduced microvascular complications, such as diabetic nephropathy or retinopathy, or diabetic retinopathy. In contrast, improvement in managing blood pressure and cholesterol level can show benefit within a shorter time frame of 2 to 3 years. And this means controlling these factors can lead to quicker health improvement and reduce risk of complications. And here is strengths of evidence A. General principles of diabetes management. As I said, diabetes management goals and clinical targets should be individualized based on the goals, the values, the preferences of the patient. For older adults who are healthy and functional, the focus should be on reducing risk associated with diabetes and treat comorbid conditions. And older adults with intermediate health status should involve them in management decision based on their preferences and available evidence. For some older patients, intensive management is not likely to provide benefit and may even be harmful. In diabetes management, evidence supports various interventions due to their proven effectiveness. Here is a breakdown of each intervention. Control of lipids and blood pressure. This reduces the risk of complications like cardiovascular disease, smoking cessation, regular and appropriate eye examination, and food care. Also, the diabetes education and self-management support for medication adherence, appropriate nutrition, weight loss, if indicated. As overweight individuals, losing weight increases insulin sensitivity and blood glucose control. For sure, increased physical activity is very important. While monitoring blood, okay, the next slide. While monitoring blood glucose levels at home is important, studies have shown that for many patients it may not be cost effective. This is often because frequent home monitoring may not necessarily lead to better outcome unless combined with appropriate adjustment. The evidence strength equal A here. Older adults with diabetes should undergo age-appropriate prevention interventions such as influenza and pneumococcal vaccination. As I said, careful annual food examination is recommended due to lower extremity infections and amputation being more common among older adults with diabetes. Screen for kidney disease by testing for the presence of albuminuria should be performed at diagnosis and annually. If a patient is taking an ACE inhibitor or angiotensin receptor blocker, there is no need for continuing screening. Education and self-management support. Yes. If the patient is clinically complex, we have to consider referral to diabetes educator, disease management program, or specialty physician care. Annual diabetes self-management training is covered under Medicare Part B. Involve and educate caregiver if the patient is cognitively impaired, significantly disabled, or has limited proficiency in English. Educate patient and caregiver about hypo and hyperglycemia, precipitating factor of it, how to prevent it, what is the symptoms, how to monitor and treat the hypo and hyperglycemia, and also want to notify the physician. Blood glucose self-monitoring when appropriate, diet and physical activity. Medication purpose of drug, how to take it, common side effect of the drug, important adverse reaction, also food care. All these things we have to educate our patients about it. So, okay, from here, Dr. Sara will continue with you. for the rest of the presentation.
Thank you so
Okay.
much, Dr. Eithar. Hello,
Okay,
everyone.
please go
Hello,
ahead.
Dr. Nada. Thank you so much for the opportunity to present today. I'm going to talk about prevention and management of cardiovascular risk factors. Cardiovascular disease is the leading cause of morbidity and mortality in type 1 diabetes and type 2. Cardiovascular disease comprises a group of disorders of the heart and blood vessels, including coronary heart disease, cerebrovascular disease, heart failure, peripheral artery disease. The American Heart Association focused on components of the major adverse cardiovascular events, including coronary artery disease, cerebrovascular disease, and heart failure. The pathogenesis include both insulin resistance and hyperglycemia. Insulin resistance promote macrovascular abnormalities through formation of atheroma plaques, diastolic dysfunction, and ventricular hypertrophy, while hyperglycemia promotes the development of cardiovascular disease through advanced glycosylated end products and oxidative stress. The risk factors, including obesity, overweight, hypertension, dyslipidemia, smoking, family history of premature coronary disease, chronic kidney disease, and presence of albuminuria, that should be assessed at least annually to prevent and manage both atherosclerotic cardiovascular disease and heart failure. Prevention and management of cardiovascular risk factors should include lifestyle modification, which is a very critical component of cardiovascular risk factor reduction in adults with type 2 diabetes. Lifestyle management includes diabetes self-management, education and support, medical nutrition therapy, physical activity, smoking cessation, and psychosocial care. In adults with type 2 diabetes, greater adherence to an overall healthy lifestyle associated with a substantially lower risk of incident cardiovascular disease and cardiovascular disease mortality. The Look Ahead Trial Action for Health and Diabetes tested the impact of intensive lifestyle intervention focused on weight loss and increased physical activity versus diabetes support and education on the adverse cardiovascular events in overweight adult patients with type 2 diabetes. There was greater weight loss and reduction in hemoglobin A1C versus control, particularly in the first year. Managing hypertension in older adults with diabetes. With regard to blood pressure treatment strategies, there are multiple societies like the ADA and American College of Cardiology, the American Association of Clinical Endocrinologists, European Society of Cardiology, and KDIGO recommended lifestyle modification for individuals with type 2 diabetes and hypertension. This includes weight loss, increased physical activity, reducing sodium intake, avoid excess alcohol, and increasing consumption of fruits and vegetables. Drug therapy for blood pressure management. The American College of Cardiology, the American Association of Clinical Endocrinology, the European Society of Cardiology recommended and set a blood pressure goal target less than 130/80 millimeter mercury for all comers with type 2 diabetes, while the ADA recommended risk-based treatment targeting a different blood pressure goal of less than 130/80 if the 10-year atherosclerotic cardiovascular risk more than or equal 15%, and a goal of less than 140/90 if the 10-year atherosclerotic cardiovascular risk less than 15%. While the KDIGO guidelines supported a lower blood pressure goal of less than 120/80 in patients with concurrent chronic kidney disease, the European Society of Cardiology and the European Association for the Study of Diabetes recommended more liberal systolic blood pressure target of 130/139 in those patients with type 2 diabetes and are older than 65 years old. All of these societies support the use of angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, calcium channel blockers, and diuretics for management of hypertension. All of these societies also recommended angiotensin-converting enzymes and inhibitors and angiotensin receptor blockers as first-line therapy for individuals with type 2 diabetes, hypertension, and albuminuria. The European Society of Cardiology included also left ventricular hypertrophy in addition to albuminuria as an indication for angiotensin-converting enzyme inhibitor or angiotensin receptor blocker as first-line blood pressure agent, and the ADA specifically included also history of coronary heart disease as indication of angiotensin-converting enzyme inhibitor or angiotensin receptor blocker. An angiotensin-converting enzyme inhibitor or angiotensin receptor blocker at the maximum tolerated dose indicated for blood pressure treatment as it is the recommended first-line treatment for hypertension in patients with diabetes and urinary albumin to creatinine ratio more than or equal 300 milligram per gram creatinine. This is level of evidence A according to the ADA grading system for level of evidence to the recommendation statements, or 30 to 299 milligram per gram creatinine, B level of evidence. If one class is not tolerated, the other should be substituted. For patients treated with an angiotensin converting enzyme inhibitor, angiotensin receptor blocker, or diuretic, serum creatinine and estimated glomerular filtration rate and serum potassium levels should be monitored at least annually. As regarding managing dyslipidemia in older adults with diabetes, lifestyle modification focusing on weight loss, if indicated, application of a Mediterranean or DASH eating pattern, reduction of saturated and trans fat, increased dietary omega-3 fatty acids and fibers, increased physical activity should be recommended to improve the lipid profile and reduce the risk of developing atherosclerotic cardiovascular disease in patients with diabetes. Primary prevention, as regard primary prevention, people with diabetes aged 40 to 75 years without atherosclerotic cardiovascular disease use moderate intensity statin therapy in addition to lifestyle therapy. This is level of recommendation grade A. For patients with diabetes 40 to 75 years at higher cardiovascular risk, including those with one or more atherosclerotic cardiovascular risk factors, it's recommended to use high-intensity statin to reduce LDL cholesterol by more than or equal 50% from the baseline and to a target LDL cholesterol less than 70 milligram per deciliter. The American College of Cardiology guidelines recommended moderate intensity statins for all individuals with type 2 diabetes, with high intensity statins for those with multiple atherosclerotic cardiovascular risk factors. There is a difference in the LDL target goals between different societies. The European Society of Cardiology and the American Association of Clinical Endocrinologists outline specific LDL treatment goal for those with moderate, high, or very high cardiovascular risk, with less than 100 and less than 70, less than 55 respectively, with the statins is the first line agent for lipid lowering. For patients with diabetes aged 40 to 75 years at higher cardiovascular risk factor, especially those with multiple atherosclerotic cardiovascular risk factors and LDL more than or equal 70, it may be reasonable to add ezetimibe or a PCSK9 inhibitor to maximize tolerated statin therapy. In adults with diabetes aged more than 75 years already on statin therapy, it's reasonable to continue statin treatment. In adults with diabetes aged more than 75 years, it may be reasonable to initiate moderate intensity statins after discussion of potential benefits and risks with the patient. For secondary prevention, all societies recommended high-intensity statin therapy for secondary prevention in individuals with type 2 diabetes, although each recommend at least 50% LDL lowering for secondary prevention. The American College of Cardiology and ADA target LDL less than 70 milligram per deciliter, whereas the European Society of Cardiology and the American Association of Clinical Endocrinologists recommended target LDL less than 55. The American College of Cardiology and the European Society of Cardiology clearly recommended addition of ezetimibe. First, if LDL treatment goals are not met on maximally tolerated statin therapy, while the ADA recommended either ezetimibe or BCSK9 inhibitors, although acknowledges ezetimibe may be preferred due to lower cost. Aspirin, as regard aspirin, all societies support use of aspirin 75 to 162 milligram per day for secondary prevention of atherosclerotic cardiovascular disease in patients with type 2 diabetes. The recommendations for aspirin for primary prevention are more controversial, although most societies recommend against the routine use of aspirin in primary prevention due to the adverse effects of aspirin and the increased risk of GI bleeding, especially in older adults. The American College of Cardiology, the ADA, and KDIGO guidelines suggest that low-dose aspirin may be considered for those at elevated atherosclerotic cardiovascular disease risk who are not at increased risk of bleeding. Type 2 diabetes and cardiovascular risk in patients with chronic kidney disease, the different societies highlighted the increased cardiovascular risk in those patients with chronic kidney disease whose persistent glomerular filtration rate less than 60 millimeter per minute per 1.73 meter square, or albuminuria more than 30 milligram per gram creatinine, and type 2 diabetes. So at least yearly screening for GFR and urinary albumin for individuals with type 2 diabetes should be encouraged. All society recommendations endorsed the use of sodium glucose transporter inhibitors for both kidney and cardiovascular benefit in patients with type 2 diabetes and chronic kidney disease, provided the GFR is more than or equal 30 milli per minute per 1.73 meter square. Also, the GLP-1 receptor agonists are recommended as second-line therapy by all societies. As regards screening in asymptomatic individuals, routine screening for coronary artery disease is not recommended, as it does not improve outcomes as long as atherosclerotic cardiovascular disease risk factors are tested. Treatment of cardiovascular disease, people with type 2 diabetes who have established atherosclerotic cardiovascular disease or established kidney disease, SGLT2 inhibitors or GLP-1 receptor agonists demonstrate cardiovascular disease benefit and recommended as part of the comprehensive cardiovascular risk reduction and glucose lowering regimen. In people with type 2 diabetes and established atherosclerotic cardiovascular disease, multiple atherosclerotic cardiovascular risk factors or diabetic kidney disease, SGLT2 inhibitors demonstrate cardiovascular benefit and recommended to reduce the heart failure hospitalization and major cardiovascular as adverse cardiovascular events. In patients with type 2 diabetes and established atherosclerotic cardiovascular disease or multiple risk factors for atherosclerotic cardiovascular disease, GLP-1 receptor agonists demonstrate cardiovascular benefit in patients to reduce the risk of major adverse cardiovascular events. A very important domain to talk about in older adult patients with diabetes is the neurocognitive function. Screening for early detection of mild cognitive impairment or dementia should be performed for adults 65 years of age or older at the initial visit and annually and as appropriate. Older adults with diabetes specifically at higher risk of cognitive decline, the presentation of cognitive impairment ranged from subtle executive dysfunction to memory loss and over dementia. People with diabetes have higher incidence of all-cause dementia, Alzheimer's disease, vascular dementia than people with normal glucose tolerance. Poor glycemic control is also associated with a decline in cognitive function and also longer duration of diabetes associated with worsening cognitive function. Sorry. Cognitive dysfunction makes it difficult for patients with diabetes to perform complex self-care tasks such as monitoring glucose and adjusting insulin doses. It also hinders their ability to appropriately maintain the timing of meals, content of diet. When clinicians are providing care for patients with cognitive dysfunction, it's very critical to simplify care plans and facilitate and engage the appropriate support structure to assist individuals in all aspects of care. Older adults with diabetes should be carefully screened and monitored for cognitive impairment. Several sample assessment tools are available to screen for cognitive impairment, such as Many Mental State Examination, ManyCog, and Montreal Cognitive Assessment, and referral to a behavioral health professional for formal cognitive and neuropsychological evaluation in patients who screen positive for clinical impairment should be encouraged. Now, this is the challenges in management of patients with type 2 diabetes among the patients with these age groups, as older adults with type 2 diabetes has several geriatric syndromes and symptoms like cognitive impairment, sarcopenia, ferality, urinary incontinence, falls and malnutrition, polypharmacy that leads to multiple drug-drug interactions, economic burden, also age-related changes in glucose metabolism, renal function, and hepatic function that consequently lead to reduced efficacy of glucose-lowering agents and increase the risk of adverse outcomes like hypoglycemia and type 2 diabetes complication, macrovascular complication, and other microvascular complications. The high heterogeneity of the population of older adults with type 2 diabetes and the heterogeneity of the individual disease course, profiling patients is essential for better personalized management in order to avoid harm and maximize treatment benefits in this case. The American Diabetes Association and Endocrine Society and the International Diabetes Federation have categorized older adults into 3 patient groups: good health, intermediate health, and poor health, based on their functional status, cognitive status, comorbidities, and life expectancy to optimize glycemic goal setting. And this is the hemoglobin A1C goals according to the patient profiles of older adults with type 2 diabetes, older adults with good health who are functionally and cognitively intact with longer life expectancy. The hemoglobin A1C goal is less than 7 to 7.5. Older adults with intermediate health who are functionally dependent with multiple coexisting chronic illnesses, the hemoglobin A1C goal less than 8 to 8.5, while older adults with poor health who have end-stage chronic illnesses, palliative or end-of-life care, they recommended to avoid reliance on hemoglobin A1C and focus on preventing hypoglycemia and symptomatic hyperglycemia. Non-pharmacological management of hyperglycemia in older adults with diabetes, including a healthy dietary pattern, energy intake of approximately 30 kilocalories per kg of body weight per day, high intake of proteins of 1.2 to 1.5 gram per kg of body weight per day, vegetables, fish, including vitamin D and omega-3 fatty acids, lower intake of meat, refined greens, sugar, and snacks could be an important dietary strategy to prevent fertility, cognitive decline, and mortality in older people with diabetes. Regular exercise, including aerobic activity, weight-bearing exercise, resistant training in all older adults with diabetes who can safely engage in such activities. Factors to consider when individualizing glycemic targets in older adults, both patient-specific and drug-specific characteristics, which determine that the glucose-lowering agents are which glucose-lowering agent appropriate for the patient, especially those older individuals with type 2 diabetes. These include comorbidities such as atherosclerotic cardiovascular disease, chronic kidney disease, heart failure, hypoglycemic risk, cognitive function, functional status, effect of glucose-lowering agent on the body weight, and their associated safety profile, individualized glycemic goals, patient preferences, and the treatment cost. And this is the oral anti-diabetic medications, metformin, bigonide, that mechanism of action with increased insulin resistance and increased insulin sensitivity, and increased peripheral uptake of glucose. Its advantages, it carries lower risk of hypoglycemia, it's weight neutral and of lower cost, while should be used cautiously in patients with impaired hepatic function or heart failure due to increased risk of lactic acidosis and GIT side effects, especially diarrhea. It's also contraindicated if the GFR is less than 30. The other groups, which are insulin secretagogues like sulfonylurea, glipizide, gliclazide, and glimepiride, glibenclamide, they are rapidly effective, but carries higher risk of hypoglycemia, controversial cardiovascular safety, especially for glibenclamide and drug interactions. It also may lead to edema and weight gain. Rebaglinide, it's also rapidly effective, but it carries a higher risk of hypoglycemia. It requires multiple daily dosing and lead to multiple drug interactions. DPP-4 inhibitors like sitagliptin, saxagliptin, and vildagliptin, it carries lower risk of hypoglycemia and it's weight neutral, but it is increased risk of hospitalization for heart failure, especially with saxagliptin. It could lead to pancreatitis, skin reactions, reduce the gastric emptying. SGLT2 inhibitors, empagliflozin, canagliflozin, and dapagliflozin carries lower risk of hypoglycemia and cardiovascular benefits, nephroprotection, and weight loss, but contraindicated in GFR less than 20. Also carries the risk of orthostatic hypotension, risk of UTI, dehydration, bladder cancer, and lower limb amputation. Thiazolidine diones, glitazones like bioglitazone, carries lower hypoglycemic risk, but it improves lipid profile, and it has anti-atherogenic effect. Risk of osteoporosis, but carries the risk of osteoporosis and fractures, fluid retention, and weight gain. Other oral anti-diabetic medications like alpha-glucosidase inhibitors carries lower risk of hypoglycemia, improve postprandial hyperglycemia, but it has GI side effects, bloating, flatulence, diarrhea, and relatively of low efficacy. Dopamine receptor agonist, it carries lower risk of hypoglycemia, improved postprandial hyperglycemia, but it's relatively of low efficacy as well, has several drug interactions and limited clinical experience in managing diabetes. Bile acid sequestrants, it lowers LDL cholesterol, carries lower risk of hypoglycemia, but it's relatively of low efficacy, lead to increased triglyceride levels and lead to GI side effects. Injectable agents, mainly insulin, basal insulin analogs like Detimir and Glargine, Degludec, it's rapidly effective, but it has anabolic effect and carry risk of hypoglycemia. Injection requires good visual acuity and motor skills, which could be challenging for older patients. GLP-1 receptor agonists like liraglutide, semaglutide carries lower risk of hypoglycemia. It has cardiovascular benefits, once weekly administration, especially with semaglutide. Disadvantages of this group of agents is weight loss, which is not appropriate in frail patients as it may result in sarcopenia, and it leads to GI side effects, nausea, diarrhea, and vomiting as it reduces gastric emptying. GLP-1 receptor co-agonist like tirzepatide carries lower risk of hypoglycemia and cardiovascular benefits. Also, it requires once weekly administration, but it leads also to substantial weight loss, which is not appropriate in frail patients as it may lead to sarcopenia, and it leads to multiple GI side effects like nausea, diarrhea, and constipation. And this is algorithm for management of type 2 diabetes in older adults. We start usually with lifestyle changes, regular exercise, and a healthy diet, then glucose-lowering agents. First step, metformin, DPP-4 inhibitors. Step 2, SGLT2 inhibitors and GLP-1 receptor agonists. Step 3, long-acting basal insulin analogs. But it's not recommended to use sulfonylurea, glinides, and short-acting insulin due to the risk of hypoglycemia, or glitazones, alpha-glucosidase inhibitors, dopamine receptor agonists, bile acid sequestrants, and amylin analogs. As regards pharmacologic intervention for diabetes with hypoglycemia, older adults at higher risk for hypoglycemia for many reasons, including insulin deficiency necessitating insulin therapy and progressive renal insufficiency. Older adults have higher rates of unidentified cognitive impairment and dementia, leading to difficulties in adhering to complex self-care activities like frequent glucose monitoring or insulin dose adjustment. Cognitive decline has been associated with increased risk of hypoglycemia, and conversely, severe hypoglycemia has been linked to increased risk of dementia. Glycemic targets and pharmacologic treatments may need to be adjusted to minimize the occurrence of hypoglycemic events. The DIAMOND trial, multiple daily injections and continuous glucose monitoring in diabetes, demonstrated that in adults more than or equal 60 years of age with either type 1 or type 2 diabetes, using multiple daily injections and continuous glucose monitoring was associated with improved hemoglobin A1C and reduced glycemic variability. Sulfonylurea in particular and other insulin secretagogues associated with increased risk of hypoglycemia and should be used with caution. If used, sulfonylurea with shorter duration of action is preferred, such as glipizide, while glyburide, which is a longer-acting sulfonylurea, should be avoided in older adults. Last topic, we are going to talk about management of diabetes across the continuum of care, especially in independent or assisted living settings, stepwise approach involving family members or caregivers, considering support available from the family staff should be encouraged. In hospital, there is a nice sugar trial that showed that increased risk of severe hypoglycemia and mortality was increased with tighter blood glucose control. So they recommended holding non-insulin therapies while the patient is admitted in the hospital. Recommended insulin for persistent blood glucose, which more than or equal 180 milligram per deciliter, and adjusted to target 140 to 180 milligram per deciliter for critically ill and non-critically ill patients. Basal bolus insulin with or without correction regimens lead to better glycemic control and reduced hospital complications than sliding scale alone. Hypoglycemia protocols for blood glucose less than 70 milligram per deciliter. Communication with outpatient provider upon discharge of the patient from the hospital. In skilled nursing facilities, 1/3 of the patient have documented hypoglycemia. It could be due to less regular food intake. So establishing protocol to alert medical providers so that management of diabetes can be assessed and adjusted as necessary for hypo and hyperglycemia. in palliative or hospice care, less stringent approach to glycemic control for stable patients, just prevent hypoglycemia and symptomatic hyperglycemia, titrate down insulin dosage as oral intake declined in cases of organ failure. In dying patients, it's recommended to stop all agents in type 2 and decrease amount in type 1. This is the recommendations for GRS diabetes mellitus based on the American Board of Internal Medicine Foundation's Choosing Wisely campaign that avoid using medications to achieve hemoglobin A1C less than 7.5% in most adults aged more than or equal 65 years old. And moderate control is generally better. There is no evidence that using medications to achieve tight glycemic control in most older adults with type 2 diabetes is beneficial. Among non-older adults, except for long-term reductions in myocardial infarction and mortality with metformin usage, using medications to achieve glycated hemoglobin levels less than 7% associated with harm and higher mortality rates. Tighter control has been consistently shown to produce higher rates of hypoglycemia in older patients, giving the long time frame to achieve microvascular benefits of tight control. Glycemic targets should reflect patient goals and health status and life expectancy, as we previously mentioned. Reasonable glycemic targets would be 7 to 7.5% in healthy older adults with long life expectancy, while should be 7.5 to 8% in those with moderate comorbidity and the life expectancy of less than 10 years, and 10 to 9% in those with multiple morbidities and shorter life expectancy. To sum up, diabetes is very important to identify and address because of the great heterogeneity in older population. Treatment goals for diabetes must be individualized. Although the target is debated, attempts to lower blood pressure as tolerated is important for older hypertensive patients with diabetes. Diabetes self-management is an important part of diabetes care, and annual self-management training is covered by Medicare Part B. Now we are coming to the last section, which are cases. The first case is a very 65-year-old woman comes to the office for her welcome to Medicare preventive visit. She uses a four-wheeled walker to assist with ambulation. Her history includes diabetes, diagnosed 3 years ago, hypertension, osteoarthritis of the knee and hip. Her medications include acetaminophen 3 times daily, tramadol 3 times daily as needed, metformin 1,000 milligram twice daily, lisinopril 40 milligram per day. On examination, BMI 30 kilogram per meter square, unremarkable cardiovascular and pulmonary findings, bilateral knee crepitus with extension with no focal pain. With the walker, gait is stable but slightly wide-based with decreased knee flexion. Hemoglobin A1C is 8.5%. Which of the following is the most appropriate recommendation? It's weight loss to achieve normal BMI, diabetes self-management education program, prescription for glipizide, or exercise prescription for walking 150 minutes per week at moderate intensity. What do you think?
Feel free to type in your answers in the chat box or just use the hand raise.
Okay.
Okay. I have one
Okay, let me.
answer. A.
Okay.
From Dr. Loy. Okay.
Any answers? Any other answers?
Not yet.
Okay. Well,
okay. And Dr. Mohammed
okay, I will
Wadidi
say.
also. A.
Okay, A. Okay, let's move to
Dr.
the.
Ramana, A. Yeah, please, you can.
Okay, move to the correct answer is B, diabetes self-management education program. Actually, weight loss is very reasonable and the first choice to improve insulin sensitivity and to reduce the weight is lifestyle interventions is very important, but actually in this patient who use 4-wheelchair and has knee osteoarthritis, it will be very difficult to exercise in order to lose weight, and also prescription of glipizide in this case it will increase the risk of hypoglycemia. So diabetes self-management education program is the most appropriate answer for this question, and all patients with diabetes should receive education that will allow for ongoing diabetes self-care, and it should be diabetes self-management education should be provided at the time of diagnosis, annually, and during transitions in care, and when new health conditions develop. Let's move to the case number 2. An 80-year-old man comes to the office with his son, who is concerned about his father's memory. The patient's wife died 9 months ago. He says he feels lonely at times, but not depressed. The son notes that his father has gotten lost a few times when driving to church, and there are unpaid bills lying around the house. History of type 2 diabetes, diagnosed 20 years ago, mild knee osteoarthritis, well-controlled hypertension. Medications include aspirin, losartan, hydrochlorothiazide, metformin, insulin glargine, insulin lespro. According to his chart, the prescriptions expired 2 months ago, and he missed his last 2 appointments. Laboratory findings 1 year ago, their electrolyte levels were normal. Normal renal function, hemoglobin A1C was 7%. Today, hemoglobin A1C is 9.5% with normal thyroxine level, thyroturbine level 8 microgram per liter. The question is, which one of the following is true about these patients' memory changes? His executive dysfunction is unlikely to be related to his diabetes, or hyperglycemia is likely impairing his condition. Correcting his hypothyroidism will likely improve his cognition, or tight glycemic control will likely improve his cognition. Sorry, this is the...
Okay, we have a couple of C's from Dr. Mona and Dr. Ahmed.
Okay. Anyone else?
Dr. Mohammed already disagrees. It's a B, and Dr. Loy says A.
Okay.
So we have, yeah. Okay, a couple of
We have,
B's
now we have...
from Dr. Mona and Eithar.
Okay.
And A from Dr. Esraa.
Okay. Let's move to the correct answer, which is B. Hyperglycemia is likely impairing his cognition, as we previously mentioned in the previous slides, that hyperglycemia affecting the cognitive function of the patient and also the duration of diabetes. Poor glycemic control, increased hemoglobin A1C, older age, all these affect the cognitive function of patients. So executive dysfunction is most probably related to his diabetes, so the first answer is wrong. As regard the C, the option number C, correcting his hypothyroidism will likely improve his cognition. When we return back, he has normal thyroxine level, while the thyroturbine level is 8, but he has normal thyroxine level, so he's euthyroid. Tight glycemic control will probably lead to increased risk of hypoglycemia, will not likely improve his condition. So we'll move to case number 3. A 72-year-old woman comes to the office to follow up on recent laboratory findings, which included hemoglobin A1C of 9. She lives alone. A hired home health aide helps her with grocery shoppings, laundry, and house cleaning every day for about 3 hours. She uses a walker for mobility. Because of a fear of needles, she refuses to monitor her glucose at home. History of type 2 diabetes, diagnosed 5 years ago. Hypertension, hyperlipidemia, advanced glaucoma, severe knee osteoarthritis, and osteoporosis. Medications include metformin, lisinopril, atorvastatin, alendronate, aspirin. On examination, BMI is 28 kilogram per meter square. her blood pressure is 140/70 millimeter mercury. All other findings are unremarkable. The question is, which one of the following is the most appropriate management? Continue current regimen, or add hydrochlorothiazide, add glipizide, or add sitagliptin? Please, any answers?
We have an A from Dr. Ahmed and a D from Dr. Mohammed Wadidi.
Okay. A and D?
D, yes.
Okay.
Yeah. And we have another D from Dr. Amuna. Yeah, we have a couple of Ds.
Okay.
Also another D from Dr. Paradis. I hope I'm pronouncing that correctly.
Okay.
Sorry if I'm not.
Okay. Well, let's also move to the correct answer, which is D, add sitagliptin. Actually, this patient is considered of intermediate health. As per the profiling of patients that we mentioned in the previous slides, she has intermediate life expectancy, high treatment burden, hypoglycemia vulnerability for risk. So for glycemic control, it's slightly more difficult for this age group, and the recommended goals for hemoglobin A1C is less than 8%. So we have to control her hemoglobin A1C. And adding glipizide in this case will increase the risk of hypoglycemia. So sitagliptin is a good option here. We will not add hydrochlorothiazide because her blood pressure is less than or 140/70, which is the target in her age group. And continue current medication. No medication and diabetic medication should be intensified to achieve the target hemoglobin A1C in this patient. And thank you so much.
Thank you so much, Dr. Sara and Dr. Eithar, for this interactive session. It was really informative.
Thank you.
We have, I think, one remark from Dr. Mohammed Wadidi. He mentioned that the new guidelines state that aspirin is no longer recommended for the primary prevention of heart attack or stroke. Thank you, Dr. Mohammed, for this update. If you would share the reference for these guidelines, that would be really helpful. We have a question from Dr. Luai. I think it's regarding the first case, and he said, self-management how? I think the answer was self-management education program, yes. And he's asking self-management how?
Okay. I just want to answer the question about aspirin. Actually, the recommendations for aspirin for primary prevention, as mentioned in the slides, are more controversial, although most societies mentioned that or recommended against routine use of aspirin in primary prevention for the risk of GI bleeding in patients, older adult patients. There are few societies that suggest low-dose aspirin may be considered for patients with elevated atherosclerotic cardiovascular risk who are not at increased risk of bleeding. So this is as regard aspirin.
And okay, thank you, Dr. Sara, for your answer.
Thank you
We
so much.
will open the floor for a couple of more minutes if any other questions. And of course, Dr. Nader, if you have any comments or feedback.
Thank you so much. This great presentation. It's an important topic, and there are a lot of debate and updates. So if you want to keep update, that would be great. Thank you so much.
Thank you so much, Dr. Nader.
Yeah, thank you, Dr. Nader. Okay, I think we can move to the following presentation if we have the presenters ready. Yes.
Hello, everyone.
Hello, Dr. Rammah. How are you?
I'm fine. Hello, Dr. Nadir. Good afternoon. And thank you for this opportunity. My name is Rammah Salim, and I'm IMG from Sudan. I'm going to talk today about a topic in a role of mobile apps in diabetes care. And I hope that I will be brief and concise in doing so. Is my voice clear?
Yes, very clear.
Okay, thank you. Okay, I'm going to share my screen. Is it appearing? Hello, my screen, is it shared?
Yes,
Yes,
we can
it's clear.
screen.
Okay, we are going to talk about the role of mobile apps in diabetes care or diabetes self-management. So we will start by briefly talk about the background and the impact of the problem of diabetes and the challenges in management of diabetes. And then after that, we are going to talk about the barrier to the effective diabetes self-management and the role of technology and mobile apps in diabetes care. And further, we will talk about the feature and function of diabetes self-management apps and challenges in their adoption. And finally, we are going to talk about the top recommended diabetes self-management applications. As we all know, the overgrowing prevalence of diabetes mellitus is continue to increase and rise in the worldwide, affecting one person in every 11 people. With the type 2 diabetes is the most prevalent form of this condition and characterized by hyperglycemia and insulin resistance. The persistent hyperglycemia could lead to development of microvascular and macrovascular complication and increase the risk of hospitalization and death. The management of diabetes-induced cardiovascular diseases and chronic kidney diseases requires heavy healthcare resources consumption and up to fourfold increase in healthcare costs. And the management of diabetes is thought to be a multidisciplinary approach, which involve the patient itself and the multiple healthcare providers. Most diabetes management is thought to involve self-management and active engagement of the patient in their management of the condition. Diabetes self-management is a term used to describe the strategies that patients use to cope with the emotional and practical issues encountered while living with a long-term condition like diabetes. The effective diabetes self-management improve the control of the condition and reduce the risk of complications and improve the patient outcomes. So there are many barriers to the effective diabetes self-management, which could be from the patient itself or from the busy healthcare settings. Here in this slide, the increased prevalence of diabetes and the increased complication. This will lead to increase in demand for clinical appointments and increase the input from the healthcare providers. This eventually leads to decreased time of the patient with their clinician to discuss the management of their diabetes and optimize the treatment. Other barriers to effective diabetes self-management or self-care could arise from the side of the patient itself, like remotely living patients have limited access to healthcare providers and lack of continuous education. The patient may lack of the interest or poorly engaged in the self-care. Then the solution for this condition to be effectively deliver the diabetes self-management to the patient is by the integration of technology in diabetes care. And this lead to innovation of diabetes self-management application, which are software applications that can be executed on a mobile platform or a web-based software application that is tailored to a mobile platform, but is executed on a server. The use of this application before the COVID-19 was limited due to hesitation from both sides, the patient and their healthcare providers. And after the pandemic of the COVID, the integration of these applications into diabetes care has been increased. There are many applications for different types of diseases, but the diabetes application account for up to 50% of the total number of disease-specific apps up to 2021. Mobile apps for diabetes self-management have been shown to reduce the barriers to and enhance patient self-management activities. A new cohort study published by JAMA Network Open in 2020 found that people living with diabetes can benefit from using self-management apps on their computers and mobile devices. And the result of this study was improved in medication adherence, and glycemic control, and reduced complications rate. Diabetes self-management apps are also improve patient engagement in their care by giving them all the resources for learning about their condition. Here are the outcomes of using mobile apps in diabetes management. They help building bridge between people living with diabetes and technology, and also empower the patient autonomy, because not all patients prefer or have the time for face-to-face consultation and education. Also, this app improves remote monitoring for diabetes patients in rural area. There are many numbers of applications for diabetes available, and these apps have different features or functions in managing diabetes while they are used by the patient. Most of them provide diabetes education, as well as provide medication and diet tracking, and continuous glucose monitoring in real time, connecting and transferring data to healthcare providers. connection with other devices like a glucometer, integration of social media function, and by this feature, the diabetic patient would find other patients in the same condition and motivated by their control of their condition through the social media integration feature of those apps and other specific functions tailored to the specific type of the applications. This application can do the nutrition and their plans, carbohydrate counting, references of nutritional values on dishes and restaurants, blood glucose monitoring like a test reminder, monitoring blood, monitoring hypoglycemic symptoms, and diabetes diary. Also monitor physical activity like giving exercise plans, tracking physical activities, and weight management. Also, they provide weight loss plan and weight tracking. Medication management like insulin dose calculator and medication reminder. Mental health monitoring the mood of the patient and well-being, social support to the patient, as well as appointment reminders. There are many challenges in the use and adoption of these mobile apps by the patient themselves and the features of the app or the healthcare provider. Those three factors affecting the adoption of those diabetes self-management applications. Firstly, the factors that related to the patient, like the patient age, with the patient, more younger patient are more likely to use the mobile apps in managing their diabetes condition. And gender, also according to studies, this app or mobile app technology in management of disease are more likely used by females than males. Education, the use of this app also by the educated type of patient, and the technology use. The more familiar the patient with the technology, the more adoption of the mobile app. Also, mobile health literacy. The high mobile health literacy in the patient, the high likely to adopt or use the mobile app and manage their condition. And diabetes status, the more acute diagnosis of the condition, more likely the patient will adopt the mobile application to help him manage his condition. Communication in the app, the apps that provide real-time communication with the healthcare providers are preferred by the patient more than the other type of application. And finally, recommendation by their healthcare providers. The patient will likely adopt or use the mobile application if it recommended by their healthcare providers. Healthcare providers are likely to recommend diabetes self-management application if they were easy to use, not complex applications, and if the app contain feature of multi-language, and if they provide real-time feedback and communication with the healthcare provider. Also, if the application provide education to the patient about the diabetes in different aspects, would be likely to recommend it by their healthcare provider. And patient characteristic, if the healthcare providers determine that there would be no benefit from the usage of the mobile app to the patient, he unlikely to recommend the application to him. Finally, the cost. If the application is free of cost, is more likely to be recommended by the physician, free of charge. Other factors affecting the adoption of mobile application related to the application itself. As we previously mentioned, the apps with ease of use, the apps that provide communication, the applications that provide real-time feedback, and the application that could be adjusted to customize setting, also preferred. Also, the applications that provide goal setting and privacy security is free of cost. All are important factors in the application to be used and adopted by the patient, as well as technical problems. If the application continue to have technical problems, it is very unlikely to be used or adopted by the patient. Language, as we mentioned, applications that provide the features of multi-language and native language of the patient would more likely to be adopted by the patient themselves. And finally, information about diabetes and latest research findings. Applications that provide information about diabetes and education to the patient will more likely to be adopted than the other applications. Finally, we are going to talk about the top recommended diabetes application. From the Diabetes Education Service website, there are many apps available for diabetes management, and it is necessary to choose carefully among the widely available mobile health application for your patient and for the patient to get the benefit and to put in your concern regarding their reliability, data privacy and security, suitability of use, and clinical benefits. Those apps should have a regulatory assessment and approval, but there is no country have this approval or regulatory assessment feature for the mobile application. In most countries, it's not available. So those apps are recommended by Diabetes Education Service website, top application for the healthcare provider to recommend for their patient. And each of the following application offers something unique and helpful for the different individuals. We start by BD Bright Diabetes Assistant, which is app for nutritional advice healthy recipes and activities, along with voice recognition to assist with logging insulin doses and blood glucose and asking questions. Be the bright diabetes assistant. The second top recommended app is Calorie King, which include information about curated food database and other nutrition information, including many fast food and restaurants. Calorie King. The third app is Figwe, which help in track what the patient eat and allow custom food entry and record progress. Figwe. And the fourth app is called Foodukate, which is a health tracker app, track what the patient eat and their activities, and finally show the progress and achievement of goals. The fifth app, MyFitnessPal, which is user-friendly and engaging app that support behavioral change. We have My Sugar app or diabetes logbook, and this app is like a video game featuring diabetes as a monster that helps patients keep motivated and engaged in their management. Also, we have OneDrop app, which empower drug analyzation of all diabetes data, including glucose, medication, food, and activity, all in one application. It allows the patient to set goals, track progress, and see the results. Also, we have Relax Lite, which is an application that helps stress management through guided breathing and medication and meditation exercises. Relax Lite. Finally, we have Tide Pool, which gives tracking tool for insulin, continuous glucose monitoring, nutrition, and blood glucose with notes as well as reports for healthcare providers. Those are the 9 top recommended applications from Diabetes Education Service website. And there are many other applications for diabetes. Finally, the CDCES Coach app, which stands for Certified Diabetes Educator Coach application. This is an app for diabetes healthcare providers and developed by Coach Beverly. And it allows quick access of healthcare providers to diabetes medication, pocket card, also give the questions of the week, and updated American Diabetes Association standard of care. Also allow you to attend free webinars on Certified Diabetes Educator. And it contains free resources for learning about diabetes. Also contain cheat sheet and feature of listening to online university podcasts. The cheat sheet of the certified diabetes educator application contained many information about diabetes, including the top application recommended for you to recommend to your patients, and also contain information about the screening and diagnosis type 2 diabetes, along with information of cholesterol medication, hypertension, and diabetes medication, American Diabetes Association pharmacological management of type 2 diabetes, the medication pocket card, hyperglycemia and hypoglycemia education teaching sheet, emergency evaluation checklist, self-care goals sheet, food care teaching, insulin history, and immunization schedule for people with diabetes, and any information about diabetes management according to the current guidelines. And this sheet updated every year or every now and then to allow you to practice the current evidence-based medicine. And by this, we are reaching to the end of our presentation. Here is are the references for this slide. If anyone have a question, please feel free to reach out. Thank you for your time.
Thank you, Dr. Rammah. Utilizing and leveraging technology is really important, of course. Thank you for this presentation.
Thank you.
Okay, we will give a window if there's any questions, and of course, Dr. Nader, if you have any comments or final remarks.
Thank you so much, Dr. Rammah. This is also an important topic, and it's better to keep up with advancement in technology and how to use it for your patients. So you can talk about it when you have some interviews. So, and it's good because some of you are involved in developing an app that's also targeting patients with diabetes. So thank you so much for this great presentation.
Thank you, Dr. Nader. If anyone have any question regarding the application in diabetes self-management care, please feel free to ask.
You can type, if you can't unmute yourself, you can type your questions in the chat box. Now, for the sake of time, if the next presenters are ready, please go ahead.
Hello, everyone.
Hello, Dr. Ghaida.
Hello, Dr. Mohammed. How are you? Hello, Dr. Nader, and hello for all the participants with us today. So our presentation is so important for everyone applying for this match season. I hope my voice is clear.
Yes, very clear.
Okay, that's great. So we can start now. Just give me a few seconds to share my screen. Is it clear? Okay.
Yes, we can see it.
So our topic today, as I said, it's vital for the participant in Match 2025, tackling virtual interview tips and tricks. I'll be presenting with my colleague, Dr. Esraa. So our objective for today is to know first the factors in residency interview and the errors to avoid in virtual interview, as well of the different types of interviews and the strategies to ace your residency interview, and the common type of questions you will get in your interview, as well as the essential preparation tips and what to do in the day of the interview and how to manage your stress and what you have to do after. So we will start with what are admissions committee looking for in a candidate? They are looking for several things, from which is communication skills, which is the most important factor they are looking for. And they want to see your ability to work in a team and to be a team player, and also management abilities, how you could manage your stress, how you could manage your time, as well as leadership skills and decision making. I think this is a vital factor to have as a candidate and in the residency, as well as advocacy skills, to speak up for vulnerable or underserved individuals and population. And empathy and compassion for your patient as well is so important. And the ability to put others' needs before your own, and reliability, dedication, perseverance, critical thinking, and problem-solving abilities. So in this slide, we'll discuss the factors program director used to rank candidates. The first important one is interpersonal skills, which include several skills like leadership skills, active listening skills, teamwork, communication, conflict solving, as you will go through your residency and have so many conflicts rise up and you have to deal with it. They want to make sure that you are prepared and ready for that. The second factor they use to rank applicant is your interaction during the interview with the faculty and the house staff, the resident and everything. And their feedback is important. And the last thing is the board exam score, letter of recommendation, and all your application CV. These are ordered. So the most important one is interpersonal skills, and the last important one is your application. It is important, but not as important as the interpersonal skills and how you communicate. There are two myths about the residency interview preparation. The first one is there are no right or wrong answers. Although there's no right or wrong answers, but there is right way to answer, a wrong way to answer. Your answer should be well thought, mature, professional answer. And this will talk. We will talk about it more in the other slides. And the next one is you can't prepare in advance, which is a big myth. The residency interview skills come with practice, and practice is the most important step to prepare for your residency interview by mock interviews with other candidates and expertise as well. So Proceeding to the next slide, we have the 5 common errors made in residency interviews, which is, as I said, practice is a key, and lack of preparation, as you are not able to present yourself well. This you can avoid it by practicing, as new habits cannot develop in a day or overnight. You have to practice for it. The second one is poor delivery. And this you can avoid it by you come early on your time, be positive, and express excitement. So faculty members can know if you are excited or if you're not by reading your body language. So you have to practice on that more. And the introduction is so important. It should be like focused and concise, to the point. Do not like over 2 minutes is not advisable. So, and you have to be confident, smooth in your speech, and all of this come with practice, and to avoid filler words. And this, you can avoid it by practicing and recording yourself. Actually, this is a great thing to do, to record yourself and then watch. It's a bit difficult, but you can see what you're doing wrong and fix the problem. The third one is lack of structure. You have organize your responses to clearly express your ideas and avoid jumping to conclusions. Demonstrate objectivity and critical thinking in your answer, and set clear objectives. Identify strength and weakness and use feedback to improve. Practice with expert, as I said. Structured practice boosts confidence, vocabulary, and helps you stay calm when facing unexpected questions. Also avoid red flag. Ensure your interview answers align with your application documents. Some interviews will only be about your application, so you have to read your application well and to align your answers in the interview with what you have written in your application. It is important to correctly identify the most pressing concern when you are faced with situational questions, or what we call behavior question. You have to show that you are non-judgmental and considerate of other perspectives. Dress appropriately, as an unprofessional appearance can negatively impact your application. And the last one is inappropriate attire or appearance, which is you have to be professional in your appearance as in your speech. So moving on to different types of residency interviews, we have 4 types. The traditional interview could be one-to-one and could be panel. The one-to-one, we have single interviewer ask questions. It could be for 20 minutes. 2 types, open or closed. As I said before, there's interview will be about your application. So this is the open interview, means the interviewers have seen some or all of your application document, including the transcript, personal statement, and everything. And the questions will only be about it. The closed interview, which the interviewer does not know anything about you other than your name. The questions will be about everything. They can ask you about your application, but it could be other questions as well. It could be with a faculty member or a current resident. The other type is panel, which involve 2 to 5 interviewers and last longer, like 20 to 45 minutes. Questions from personal to situational. And it also could be with the faculty, resident, or community representative, which will assess your communication skill. The third type is the multiple mini interviews, which consist of stations, 8 to 12 stations, each with different interviewer. You have like 2 minutes to read a prompt or question, and you have 4 to 8 minutes with each interviewer. to respond to the question, and you could have also follow-up questions according to your answer. And the interviewers include faculty, resident, and community members as well. The hybrid interview, which is both traditional and multiple mini interviews, but the most common ones are the traditional ones. Rarely you can find multiple mini interviews or hybrid ones. The hybrid is a mix, as I said. They could be interviewers of faculty members, current resident, and a community member as well. So I came to the end of my part. My partner, Dr. Esraa, will continue.
Thank you, Dr. Ghaida, for your presentation. Is my voice clear?
Yes, it's clear. Go ahead, please.
أنا ما Um, uh, is my voice clear? Hello?
Yeah, it's clear.
Yes.
Can you share the screen, Dr. Ghaida? Sorry for me.
Okay, I will.
Yes, thank you. Thank you, Ghaida. I will proceed with how to tackle virtual interviews. I will talk about proven strategies to ace your residency interview. First, while preparing for your interview, you have to think like the interviewer. You have to, as Ghaida said, you have to reflect on your own performance. Always evaluate yourself and monitor your own progress. And secondly, you have to learn how to manage your stress, and we'll talk about this in more depth in the next slides. And then you have to think before responding to any questions that you have been asked about at least twice before answering it. And then you have to use the primacy effect to your advantage. The primacy effect is that the people recall earlier events better than the later events. You have to start your interview with a smile, greeting the interviewer by the name and introducing yourself. Also, you have to master your nonverbal communication skills like eye contact, facial expressions, genuine smile, and body posture. Also, you have to remain non-judgmental when answering a scenario question in the behavioral questions section. And you have to learn to identify the type of the questions and have a strategy for it. And we'll talk about the different types of interview questions in a minute. You also have to learn to identify the different types of questions that you will be asked about and the common themes and have a strategy for each. You will have a better chance of acing them during residency. Moving forward with more strategies, you have to familiarize yourself with the professional ethics, as many questions are about how to have an informed consent, about patient autonomy and confidentiality and professional boundaries, and so on. And you have to also get comfortable with awkward silences that might happen during your residency interview. And don't forget to say your goodbyes, something called the recency effect. As we talked about the primacy effect, we have the recency effect, that people remember the last piece of information presented to them in more detail than what said earlier in the conversation. Also, you have to simply smile, thank the interviewer for their time, and politely say goodbye. And while preparing for your interview, you have to dedicate about at least 6 to 8 weeks preparing for the interview, and you have to avoid over-reliance on books and guides. You have to practice and have a realistic mock interviews, recording yourself, as Dr. Ghaida previously said. And remember that perfect practice makes perfect interviews. Moving forward for the common types of interview questions, as I said, we have the personal questions, of course. They could be an open-ended personal questions, questions about specific experiences or traits, and also it might be to identify the lessons learned and skills exhibited and relate those lessons and skills to your future profession during your residency. Other types of questions, we have the program-specific questions. You might ask, why would you like to attend our residency program? And also we have the scenario or situation-based. These are the behavioral questions. It could be about conflict of interest, ethical or moral dilemma, also professional boundaries, obligations, ethics. It could be evidence-based practice, how to have a non-judgmental approach in resolving a conflict or so on. Other types of questions, we have policy-based or hot topics questions in medicine. And also there is quirky questions. These questions are a kind of weird questions that you might be asked, and these questions are designed to surprise you and to throw you off your game. And one of the main reasons of these questions are asked is to see how you will react under stress. Lastly, we have kind of collaborative or task-based questions. Here you might be asked to work with another candidate or with the interviewer himself to solve a problem or to create a plan, maybe, or to teach each other something, or to argue opposing sides of an issue, or to act out of a scenario, and so forth. I have more preparation tips regarding the interview. In the likely case that your interviewer asks you whether you have any questions for them, you must always have few questions prepared in advance. This is not only an invaluable opportunity for you to learn about the program, but it's also a chance to demonstrate to the interviewer your commitment and interest in the program. You have also to be prepared to answer follow-up questions about any activity in your application. You have to read your application, particularly if it is an open file interview format. You have to listen, as we said previously, sorry. You have to listen to yourself, speak all the time, overusing words and phrases as like so. These words need to be eliminated from your vocabulary as to prevent you from coming across as a professional, confident, clear, and succinct. You have to also be careful about not speaking ill of others, especially if you are trying to raise yourself up by putting others down. In addition to always shedding positive light on yourself and others, always finish each question you are asked with something positive. You don't want to end your response on a negative note, because the last thing you say is what is going to be remembered most by the interviewers. You have also to take full responsibility for all your failures or weaknesses. Failures or weaknesses like could be a clinical job or something like that. It's not about saying to have or to acknowledge your limitations. More tips that you have to take your interview seriously, and your interviewers will take you seriously. Your interviewers will be able to tell that you prepared. It will be obvious that you prepared for your interview, and they will appreciate that you did not take this opportunity for granted. Also, you have to see the interview as an opportunity, not a barrier. Whereas the rest of your application is evaluated on paper or online, interview is your chance to share about yourself and to show your personality in person and to take advantage. You have to take advantage of the interview and enjoy the experience. Moreover, while preparing for the interview, as Dr. Ghaida previously mentioned, you have to wear something professional. One of the most prominent things the interviewer will notice is how you dress. As such, you should make sure that your attire and experience are professional. You could wear a gray, navy blue, or black suit with a light colored shirt or blouse. You have to keep your hair neat in a comfortable way. Having a fresh haircut is a good idea. Also, we talked about nonverbal communication. Nonverbal communication, we mean what you're doing with your body as you speak. Above the shoulder, this includes maintaining eye contact to show engagement, showing appropriate emotions through facial expressions, and also nodding your head to demonstrate your understanding and agreement with the other interviewer. You should also refrain from laughing and smiling nervously. This shows a lack of confidence. Also preparing, you have to prepare for the computer setup and the room setup during the interview. Your interview should be conducted using a desktop or laptop, not your smartphone. You should consider the positioning and the distance of your camera relative to your face and body. To encourage making eye contact and good posture, place the camera at the eye level. You should sit at a comfortable distance from your computer camera so that your upper torso is visible on screen. And if you are someone who gestures with the hands, you want your hands to be visible. Lastly, use a high quality microphone and check to make sure that it's functioning properly. The room setup, the background that is visible on the screen should be fairly clean. We recommend doing the interview in front of a blank, neutral colored wall, or at least one that is minimally decorated. You don't want anything in the background to distract the reviewer from your response. Also ensure the lighting of the room is appropriate. You want your face to be well lit with natural looking light that's coming from sides rather than from above or behind. How to manage stress while preparing for the interview. First, it goes without saying that going through the preparation process, including familiarizing yourself with the interview and the questions types, practicing in mock interviews, and getting expert feedback will make you feel more at ease at your actual interview. The more realistic you practice is the more comfortable you will be. Furthermore, you may learn something new about the program by speaking to a current resident. This is highly recommended, which may become useful for your interview. You can ask them why they selected the program and why they find it challenging about it, so that if you will be asked similar questions during the interview, you will have another perspective to incorporate their answer into your answer. And remember, while the interviewers decide if you are a good fit for their program, you are also deciding if the program is a good fit for you. Consider that you are about to invest several years of your life in the program. You need to be happy with all the aspects, including non-academic factors, such as environment, location, wellness programs, and so forth. You're also choosing them as much as they are choosing you. This mindset will help you to remain confident during your interview. Lastly, after the interview, you have to send an email, a thank you note, within 1 to 3 days after your interview. We also highly recommend to send a letter of intent The letter of intent is a letter that is sent to the director informing them that their program is your top choice. Unlike the thank you email, the letter of intent is a document that can absolutely have a positive impact on your application. That's all regarding how to prepare for your interview. I hope it was informative. Thank you guys for listening.
Thank you so much, Dr. Ghaida and Dr. Esraa, for this relevant and informative presentation. I know a lot of these of the junior and senior fellows will be applying this year. I wish all of them good luck. Thank you so much. Please, Dr. Nader, if you have any comments.
Thank you so much, both of you. This is great topic and great tips. Thank you for sharing. Hopefully this will help some of you when you go through the interview process. I don't have anything to add, but I think practice is number one that you need to do. If you can organize yourself into small groups, 2, 3, and you can work together. One will be the program director, maybe another one will be faculty, and then you will be the interviewee. So, and then you can divide the roles, just rotate. The thing is, as much as you need to practice to just be confident during the interview. Thank you.
Thank you, Dr. Nader, for your kind comments. I think we had a question during the session from Dr. Rammah, and she's saying, can you please give us an example of behavioral questions?
Yeah, so there's many types of behavior questions, but the main ones you will be asked in your interview, the ones that will ask you about to describe situation where you had to handle a high pressure or stressful scenario, or a conflict with a colleague or a resident you had through your work. And also discuss a project where you had to collaborate with diverse personalities. How did you manage different working style and that type of question?
Thank you, Dr.
hope that
Ghaida, for
answers
your
your
answer.
question.
I think we have an important note here from Dr. Umar, and he's saying that the letter of intent should be sent only to your top choice program, and you should avoid to send it to multiple programs to avoid inappropriate behavior. Thank you, Dr. Umar, for this important comment.
Thank you, Dr. Umar.
Okay, I think can move forward to our next presentation. Dr. Nader.
Yes, go ahead.
Okay. If the presenters are ready, please go ahead.
The last topic is about the project updates. Anyone with any updates that we don't know? I know some of you submitted abstracts and some of you got responses. Any of the If not, that's fine. So any questions about the program? Any new ideas, new projects? I know you are busy preparing your application. But if anything that we can help you with, I'm writing the letter of recommendations at this time. So
Hello, Dr. Nadir.
hello.
I just have a question about the letter of recommendation. The letterhead, what would it be like? Is it the University of Michigan or?
It will have this title, the Telegeriatric Research Fellowship. So it's an independent program now.
Okay, thank you.
You're welcome. If you would like a different letterhead, you can approach Dr. Ahmed. He is with our program. He works at Mayo Clinic. So if you want to approach him, he may be able to help you guys as well. Thank you. Any other questions?
Just if you have his contact or email, Dr. Ahmed.
Give me a second. Any other questions or comments, suggestions, new ideas? If not, that's fine. I'd like to thank you so much, Dr. Mohammed, and all the presenters today. I'd like to thank all the attendees for coming over. Thank you so much for your time, and thank you for your effort. I wish you all the best, and good luck with your application process and everything you do. Thank you. We'll see you next week. If you have questions, please reach out. I'll be happy to help, and Dr. Ahmed as well will be happy to help you guys. Wishing you all the best. Assalamu alaikum.
Bye. Thank you, Dr. Nadir.
Thank you,
Bye,
Dr. Nadir.
Dr. Nadir. Thank you.
Thank you, everyone.
Bye.
Thank you, Dr. Nadir.
Thank you so much, Dr. Nadir.
Thank you. Avinash. Good to have you.
Yes, sir.